Okay, well, I want to welcome everyone to another webinar in our Voice AI Summer School series. These webinars cover a variety of topics related to the use of voice as a biomarker and are part of the Voice AI project that itself is part of the larger NIH Bridge2AI project. I'm pleased today to introduce a couple of colleagues and friends of mine who will talk to us today. The first speaker is Dr. Philip Payne, who is, as you can see from his multiple titles here, I won't read them all, but probably most important is the Janet and Bernard Becker Professor and Director of the Institute for Informatics, Data Science and Biostatistics at Washington University School of Medicine. He is also a co-PI of the Voice AI project, heading up with Dr. David Dorr of OHSU, the Skills and Workforce Development module. He will be joined in his talk by Andrea Krussel, who's also involved in the Voice AI project, the Voice AI Summer School. And as you can see, her title is Director of Education and Workforce Development of the Office of Health Information and Data Science at the Washington University School of Medicine in St. Louis. She's also a PhD candidate at the University of Illinois Champaign Urbana. So the title of their talk today is Artificial Intelligence in the Learning Health System, Leading and Implementing Digital Transformation. So I will turn it over to them.
Okay. Thank you, Bill. I should also mention that Philip and I wear another hat at Washington University, and that's on the Digital Transformation Implementation Team, which is part of the Washington University 10-year strategic plan. Philip is leading that effort, and I'm working with him in the context of education and how we create digital competencies. So I feel like this is relevant information for this talk.
I think you ended up on mute, Andrea.
That's really weird. Okay, so today's talk will discuss AI in the context of its application to health and healthcare, how we, and specifically in building and operating an AI-enabled learning healthcare system. We'll provide a framework for leading digital innovation and implementing an AI-enabled learning healthcare system, and identify best practices for digital transformation and AI adoption via a series of relevant case studies. So AI, I like this slide because it's just AI in your face. So the future of medicine is artificial intelligence, and it's here. And it turns out that we are all here because NIH has launched Bridge2AI, which is meant to build a bridge connecting biomedical and behavioral research to artificial intelligence. And I'd be remiss if I didn't mention that we specifically work on voice as a biomarker of health on the Skills and Workforce Development team, where we are advancing personas, competencies, and curricula for key populations in order to build a virtuous learning cycle. And that learning cycle is displayed here. Through this work, we're forming communities of practice, identifying information needs, tailoring and delivering training content, demonstrating mastery of the competencies in real world context. That's at least where we're hoping to be, and then tracking and continuous improvement. So back to AI and healthcare. AI is dominating the healthcare IT space. A study done by Gartner reveals that healthcare leaders and business leaders, on a scale of 6 out of 7, they very much believe that the importance of technology it's very important and imminent. And you can see the types of AI that's already being implemented across the healthcare system. Whoops. And then we're currently in this hype cycle for artificial intelligence, which I like this hype cycle. We're in this innovation trigger, so we're all really excited and we're developing a lot of stuff right now. And we're starting to move into the peak of inflated expectations, meaning that this is the period of time where we are going to be seeing success stories and failures. A lot of times, things that fail are not going to go any further. So we're going to be seeing we're seeing a lot of things popping up, and whether or not they stay is the question, whether or not they'll make it to the slope of enlightenment or plateau of productivity. And these are some examples of hospital AI domains and example use cases. So we're seeing this across the healthcare system. A lot of these AI technologies are really actually meant to advance the mission of a lot of these institutions, including optimization of point of service care, improving patient journey with data at all points of care delivery, and quality and safety. And then in the context of physician groups, very similar that these are aligning with the mission and from an operational standpoint, helping to reduce costs, especially in this context of continuity of care, network and market insights, and clinical operations. And then this is a slide that I think, Philip, I like this one. This is in a lot of the AI talks that you give, that AI in biomedicine is not meant to replace human decision making. In fact, that we are very unique because we make sense of the world and we recognize and apply patterns. This is known as our personal construct theories, where computers cannot do that. You put your stuff in the computer and then it spits it out. They have a potential for bias, and they're limited by the nature of the available training data. And so they really cannot work without us. So, and I also want to know the perceived intelligence of modern AI is a function of speed as opposed to innate knowledge or reasoning. And how do we create artificial intelligence? So just really quickly, in 4 steps, we're going to acquire, and you can think about it in terms of our voice as a biomarker of health project, where we're building an ethical database where we're collecting said data. So we're acquiring the data, we're training the model via multiple methodologies, and then deployment of the model is based on the right time, place, and format. And then, of course, continuing to monitor and optimize the model. And so now I think you all can go out and do that based on what I just said. And I'm going to turn it over to Philip, who's actually going to frame the opportunity in the context of the learning healthcare system.
Sure. Thanks, Andrea. I always love this slide, by the way, with the 4 easy steps to artificial intelligence. There's nothing easy about any one of those steps, but I think one of the key takeaways there is that this is a replicable process that always begins with data. And I'm often prone to saying, when I talk about artificial intelligence and its promise, that there is no AI strategy without a data strategy. And I think that's a large part why the Bridge2AI program and voice in particular is so important, because without these large data sets, we are not going to be able to build or assess the sorts of models that we are interested in today. So, this slide is really meant to frame up an opportunity that I think lets us consider the role of artificial intelligence in a broader sort of setting, and that is what is often referred to as a learning health system. And there's been a lot written about the concept of learning health systems, including seminal reports from the National Academy of Medicine, a variety of reports in the peer-reviewed literature, and also sort of more recently descriptions of policy agendas or funding agendas that are needed to implement this model. There's actually nothing particularly remarkable about the learning health system concept. It is, as simply put as possible, a healthcare system where every time we interact with patients, it's an opportunity to learn and improve the care that that individual receives, or that their family receives, or that their community receives. And another critical part of the learning health system concept is that it creates a virtuous cycle. So we often talk about things like evidence-based medicine, which sort of conceptualize the research to practice continuum as being sort of a linear process, right? We conduct research, new evidence is created, and then we hand it off to practitioners. Never shall the two meet again. But in a learning health system, there's actually feedback cycles from the practice and population health end of the spectrum that in turn inform the types of hypotheses that are evaluated by researchers. And in that way, you create much more of a rapid learning system. That really goes back to this idea of the learning health system label. But if you take nothing else away from this slide, it's that the learning health system is not a built environment or a set of technologies. It is a set of behaviors. And I would point out that informatics as a scientific discipline is uniquely positioned to address this behavioral computational interface, which is at the core of how we build a learning health system. So if we go to the next slide, I'm sorry, Andrea, you're gonna have to drive for me. I do want to reiterate this most important point. Every time we interact with a patient in the learning health system, it's an opportunity to learn and improve. What that also means is that research is deeply embedded in the learning health system. It's not something that would be nice. It's not something that we do on occasion. It's not something that happens episodically if there happens to be funding or a protocol or a project that's recruiting a cohort of patients. But in a learning health system, every single time we interact with the patient, we are collecting the data necessary in order to learn and improve. And I think we could all agree that today, for example, with the proliferation of electronic health records and other point of care information systems, we do not always design or use those systems in a way that's compatible with this view. So back to that idea of behaviors, one of the behaviors in a learning health system is conceptualizing the role of these technology platforms as not being just for medical legal documentation or billing purposes, but also for the purposes of deeply phenotyping patients and understanding how different phenomena of interest influence outcomes for those individuals receiving care. So if we go to the next slide. So I mentioned this idea of, a virtuous cycle. And if you take nothing else from this slide, it's that informaticians produce diagrams with boxes and lines. So the idea here is that in that virtuous cycle, we begin with this idea that there are healthcare operations as well as research ideally happening side by side on a regular basis. And they're producing large amounts of data. And this is where sort of methods and theories derived from biomedical data science and informatics become very important, because we have to organize and make sense of that information, which is multimodal, multi-scale, and it has complex temporality, and generate analyses and insights that can then be delivered in the right time, place, and format. Ideally is something that's contextual and has sufficient meaning to become actionable. And that's really information, if you think about this sort of data to information to knowledge life cycle. If you think of this in a biological frame, this would be an afferent process, right? Collecting these signals, making sense of them, and then delivering insights. And this ultimately gets delivered in a variety of different sort of context appropriate manners. And then we need to understand how that new knowledge impacts clinical decision making, as well as sort of more generally patient decision making and outcomes. And this is where disciplines such as decision and implementation science, as well as some of the more practical issues around digital health and digital transformation become central. And then we have to evaluate and optimize. So this is where we monitor continuously what is happening in that system. A great example today is the proliferation of work around how do we monitor modern clinical decision support systems. And you may have heard terms like algorithmovigilance, right? This is the idea that because these dynamic systems impact the dynamic system in which they're situated, we have to constantly evaluate and see how their use changes over time and then adapt. That would be an example of that evaluation and optimization cycle. And ultimately, we use that to understand, are we having the desired impact? And then feed those signals back into operations and research and repeat. And that second component I just described, again, in a biological frame, is that efferent process. So again, not a unidirectional flow of research into practice, but a continuous cyclical model. So if we go to the next slide. And this goes to sort of the core of today's talk, and of course the work in Bridge2AI, which is this intersectional space of artificial intelligence and what I'm going to describe as digital transformation. And digital transformation at the highest level is a process where we are trying to create positive change in an environment through the use of modern computing and communication and connectivity technologies. And this is not just a healthcare specific phenomena. This applies to almost every possible domain that you could imagine applying data and computational and communication tools to. But I will call out that there's an important difference between digitization and digital transformation. Because digitization is about how do we take existing processes and use computers within the frame of that existing process. Whereas digital transformation is where we think about how do we completely re-engineer the process to maximize the impact of computation and communication and data. And so these are two fundamentally different things. And digital transformation is a lot harder to achieve because it is fundamentally, back to my prior arguments, about changing behaviors, culture, and incentives, and engaging in change management, not so much about just technology and how that technology is deployed and used within existing processes. So if you sort of put all these pieces together, if we want to create this set of behaviors in which we learn every time we interact with patients, and we want to sort through and make sense of all that data, information, and knowledge, we're going to need better tools to be able to filter, understand, and deliver all of that content. And that is where AI and digital transformation come together with this vision of the learning health system. So if we go to the next slide. And I apologize, Andrea, where am I handing this off to you? Because I can't see the slide numbers.
Oh, you keep going.
All right, perfect. Thank you. So I apologize. We have slide numbers. We just can't see them in Teams. So there's an example of digitization, not digital transformation. So if we're going to build this AI-enabled learning healthcare system, then I would argue that there are 4 critical questions that we have to ask every time we seek to use AI in this context. And these are not remarkable questions, but they are questions that I think we often overlook in the design and execution of these types of projects. They begin with the fundamental question of whether the task that we are seeking to transform using artificial intelligence is the right kind of task to either create or sustain the behaviors that comprise the learning health system. And then if we decide that is the case, the next question, back to the idea that there is no AI strategy without a data strategy, is do we have the right data to pursue the project with? And even then, and that's a hard question to answer, if we do have the right task and the right data, do we know what the evidence standard is that is necessary in order to sort of assess success? And I'll talk a little bit more about that in a moment, but this is a very hard problem. What is the comparator, right? It's hard to have an evaluation plan if you do not know what the comparator is that you're going to use for the purposes of saying whether or not you've improved outcomes or some other desirable characteristic. And then finally, even if you have the right task, the right data, and you know the evidence standard, you still have to bring it back to people to use in the real world. And this is where human factors, cognitive, decision, and implementation science, and a variety of other aligned disciplines become absolutely essential. Because as I often say to my trainees, you could have the best algorithm or the best tool in the world, but if people can't actually access it and use it, you will still fail. So we cannot treat that as sort of icing on the metaphorical cake, but rather we need to sort of set out with this goal of integration from the outset. So now if we go to the next slide. And this sort of plugs into this idea, which I think is very durable, but often, again, overlooked, which is called the intermediate effect. And this is sort of a well-understood cognitive science phenomena. And in this intermediate effect, if we introduce a new technology into an information-dense environment, the most likely outcome is that performance at a given task is going to decrease before it gets better. The reason for that is that human beings, back to this idea of personal constructs, make sense of the information world around them through pattern recognition. And we actually have unique cognitive strengths in terms of pattern recognition in light of missing or incomplete data that computers still have not fully replicated. However, if you introduce a new technology, technology is not really benign. It will actually change the way in which data and information is organized, delivered, and understood. And that can in turn negatively impact the ability of humans to apply those pattern recognition skills to that data and make a decision. And that's where sort of this idea of inefficient decision making happens. And usually there's this period at sort of the bottom of that technology adoption curve, which we refer to again as the trough of despair, which is where we often declare this new technology doesn't work. Usually that's because we haven't addressed issues like how people accommodate to the new technology, how we may optimize it to meet workflow needs, how we support those individuals or provide appropriate training. Because if we do those things at the right time and place in that trough of despair, we can then sort of move further down this curve and arrive at what will ideally be a new performance level. And the reason why I bring this up is sort of this performance versus time curve is very important when we consider sort of how do we integrate AI into the complex clinical environment. The metaphor I often like to use is a lot of times we deploy AI tools today like we were teaching someone to drive who had never seen the inside of a car, let alone a car on the road. So we put them in the car and we basically say, here's the steering wheel and here are the pedals, good luck. When in fact, what you really need are driver's lessons. So you learn the rules of the road and you understand how a car operates and you have some baseline before you yourself try to drive a car. And I think we could all agree in this particular discussion that more often than not, when we bring technology in the healthcare environment, we are not providing that level of support, training, and contextualization, which is why that fourth point in those 4 critical questions is so incredibly important. All right, if we go to the next slide.
Okay.
All right. So with that as a starting point, I'm going to hand it back to Andrea because I've sort of introduced this idea of the learning health system and how AI is central to sort of operationalizing the learning health system. But there are some real leadership challenges to affecting the cultural and behavioral norms that make this work. And that's sort of the next part of this talk. So Andrea, I'll let you take it from here.
All right. So we've provided a discovery-driven digital innovation framework. So again, it's digital innovation in 5 easy steps. So what we asked to do is to define the operating experience and to remember that this is the interaction of people and technology combined with other drivers. We want to focus on specific problems and identify outcomes. Specifically, we want to get feedback from people who are actually utilizing the technology versus those that are perhaps in positions where they don't have to. And then kind of going back to what Philip was speaking to earlier about digitization, not digital transformation, is that predefined return of investments, they usually respond to the digitization, not the process of digital transformation. And that innovation should include a lot of evaluation and business models and measuring impact. We want to identify, understand, and leverage competition. Look for platforms, not point solutions. So invest in scalable, adaptable capabilities, which will actually simplify decisions in the long run. And be willing to learn and adapt based on failures, fail fast. Risk can be managed, but it shouldn't be eliminated. That actually can be a driver for success here. And then identifying transformative use cases and operating models. So new technologies can transform solutions for a given use case. And these transformative solutions can reflect a combination of generalizable features such as personalization, sharing of assets, collaborative capabilities, and being agile in your deployment and optimization. And they are not always disruptive. And we've discovered this as we've been working through digital transformation at the university, that actually it can be pretty easy to implement. So Philip, for example, we recently launched ChatGPT that's for our university. So and that happened very fast. It was kind of a miracle. We've never done anything so fast with IT before. I don't tell anyone I said that. And basically, our users are able to put HIPAA and FERPA data into the model and get answers to their questions. And it did not really, that was not a disruptive solution. That was a quick and easy solution that's helping people work more efficiently. Another myth is that digital will replace physical. It's a both and. Again, the digital is enhancing what we already do, not replacing. That it can only be pursued by small or agile organizations. Large organizations can partner with these smaller organizations in a mutually beneficial manner. We've certainly been doing a lot of partnering with consultants as we've gone through our own digital transformation. That digital is just about technology. It is not, it is about the end user and solutions for said end user. And that digital requires the complete overhaul of existing tools and technologies. A lot of times it is bringing tools together or even highlighting tools that already exist that nobody is aware of. And digital requires data, as Philip said earlier. If you're going to have an AI strategy, you need a data strategy. So these solutions require vast amounts of accessible, fit-for-purpose data. Building and leveraging such assets require a coherent strategy, and they need to balance two fundamental viewpoints: on the defensive, so addressing governance, privacy, cybersecurity, and then on the offensive, which is addressing the tools and methods that you need to make sense of complex multi-scale and multimodal data. It is rarely static and it is constantly changing. And I like I like this: good governance equals good data. So make sure you have the right people in the right room, making sure that all of these things are working. And AI creates value. So the data and technology domains are shifting towards an operating model in which AI is the primary driver of value creation. This is the blurring of lines between traditionally distinct problem and solution domains. And as a result, leveraging AI for value creation requires a system level view. So from operations to strategy to competition. And again, it's not a technology-centric discipline, it's a function of systems thinking. So in terms of successful AI adoption, it requires putting AI at the core. So technology and talent are not enough, and cultural and organizational barriers need to be prioritized. So this is something that we have encountered, just a lot of mistrust to AI among stakeholders and individuals at our university. How do we overcome these barriers? How do we communicate the benefits? And so a lot of this has been an exercise in change management and communication strategy. And leadership of AI in this context requires creating a sense of urgency, organizing work in a manner consistent with AI maturity, embracing and adapting to complexity, achieving the necessary agility and pacing of AI projects, and then investing in and advocating for AI education and upskilling, which is certainly something that we are doing at Washington University for staff, faculty, students, and even alumni. And I won't touch on all these, but here are some ways if you want to launch an AI project, don't do this. So you want to make sure that you have an understanding of advanced analytics. Make sure that you are assessing feasibility, value timelines, and pilots and measuring them. Not developing a strategy beyond just a few use cases. I find that with AI adoption, sometimes it's throwing spaghetti at a wall and whatever sticks. People are like, that works, instead of actually evaluating it. Not defining roles and responsibilities, and failing to account for the ethical, social, and regulatory implications. These are all things that could derail your potential project. And Philip, I'm going to turn these two slides over to you and let you take it away with the rest.
Yeah, so if you try to stitch all of those sort of leadership best practices together, and you think about this idea of building a learning healthcare system that's AI enabled, what you ultimately land on is that you need to have an AI operating model. And the AI operating model is really sort of, to be metaphoric, where the rubber meets the road. You have to have a portfolio of potential solutions. So to translate this to the Bridge2AI Voice program, through our various mechanisms, we will be catalyzing a community that's going to be developing novel algorithms that interpret voice recordings and help us to derive biomarkers that can be used for diagnostic and other sort of purposes in the clinical environment. So that in itself will start to build through that community a portfolio of potential solutions that have both research and clinical applications in this learning health system. However, if you're going to go from I have that library to I'm going to get people to use these again in real world settings, now you get into sort of the strategy side of the spectrum, right? So this is where you have to map those solutions to all the factors that Andrea just introduced, right? Understanding what creates value for the people that you want to use these tools, aligning that with technical feasibility, policies, culture, understanding risks, and ultimately creating incentive models that allow for adoption to happen in the sort of environment that we actually live in. For example, a complex clinical care environment with razor thin economic margins amongst many. And this all leads to that sort of operating model where governance and data and literacy, sort of getting people mobilized, making sure you have the data and that you have sort of introduced these concepts in an accessible manner to all those stakeholder groups becomes central. And then there's all sorts of engineering and technology problems. But again, those are not the only problems to be tackled, but rather part of this broader constellation. And it's really when you think across sort of this readiness to sort of execution spectrum from you build the portfolio to you map the portfolio to strategy to you create an operating model that allows you to achieve increasing degrees of maturity, that's when you start to see impact and outcomes in those real world settings. So if we move to the next slide. And I do want to emphasize, if nothing else sticks from this talk, it's that in order to do what we're talking about today, to go from research and development to implementation to impact of AI in this learning healthcare system, you will without a doubt need a vast array of people with different backgrounds and expertise, right? These are people that are in the trenches doing the work that will be impacted by the AI. They are the people that design and evaluate and really help to render translatable the AI solutions. And then you have the people that are more the technology operators and implementers that can bring those types of solutions at scale into the clinical environment. And there are people that exist at these sort of critical intersectional spaces, such as data engineers that understand the data flows and sourcing, back to the idea that there is no AI strategy without data. Or the business translators, people that understand sort of the endpoint, perhaps it's clinical or research oriented, and can map between those desired outcomes and technical capability and help sort of guide that human computer interface at that sort of translation level. Not to mention sort of engineers, architects, and people that look at real world process, right? Not just technology, but workflow and process engineering. And this is also why the skill and workforce component of Bridge2AI is so important, because one of the things that we're trying to do is build scalable and flexible competency-based models, back to that sort of educational framework that Andrea introduced earlier, that allow us to really meet the needs of all these different groups that will need to be oriented and engaged and acculturated to sort of these core concepts so they can go from research and innovation to practice to impact, as I described before. So if we go to the next slide. So I'm going to just give you sort of to round out the conversation, a few example case studies from WashU and our healthcare delivery partners at BJC Healthcare, which is a 28 hospital integrated academic health system. And the goal in doing that really is not necessarily to highlight the research so much as to talk about some of the practical barriers that existed to implementing these AI solutions in the learning health system that we're trying to build throughout our academic healthcare enterprise. And I could have given you a lot of examples, but I'm just going to give you a few. So this is an example of a project that was born of sort of operational demands in our critical care units, where we were seeing increasing numbers of adverse clinical outcomes as a function of polypharmacy involving opioids and other medications. Now, we know that there's a lot of challenges around the appropriate use and management of opioids for pain relief in the hospital, and that patients who often have procedures or other clinical conditions that require this level of pain management often have other comorbid conditions and therefore medications that they're being prescribed for those conditions. And one of the things that we did was actually evaluate using more advanced machine and deep learning methods what were unanticipated adverse outcomes that happened for patients that were being prescribed opioids and other medications. And what we actually found were a number of commonly occurring conditions where there was some belief system based upon that sort of data analytic approach that there was a causal relationship. And this was across a spectrum from cardiovascular complications to sort of conditions like sepsis and many in between. And the takeaway here was actually that it required that translator level to turn this into sort of an actionable solution that could be used by a critical care team. So as you see here, there's two key investigators involved in this project, one of whom is an applied mathematician that works on this type of deep learning approach to mining EHR and biomolecular data, Fu-Hai Li, partnering with a practicing critical care physician who was able to define that driving clinical problem, that we needed better decision support for these unanticipated adverse outcomes that weren't in standard documentation or other knowledge sources, and then was able to translate that into a workflow that made sense in the electronic health record in our ICUs and other critical care settings. So I bring that up as an example of sort of the team-based science that's necessary to move from sort of an interesting data analytic finding, unanticipated adverse outcomes associated with opioid use and other drugs, to a practicable clinical decision support intervention that could be used by critical care teams in the ICU. So this is a project that has a sort of primary example of the essential role of that translator that was alluded to earlier in some of the material that we presented. So if we go to the next slide. So sort of now looking at a different problem, but not entirely sort of far apart from the first, is the issue of sepsis. Now, you couldn't talk about AI in a clinical environment these days without bringing up sepsis risk prediction algorithms at least once. It seems to be a requirement, and everybody's working on this problem. But one of the interesting issues is that there is really a multitude of mortality risk prediction tools that can be used to assess risk of death for individuals who have been admitted to the hospital and in particular to the ICU. And you've probably heard of many of these risk prediction algorithms. However, and this goes back to right task and right data, some of the questions that I talked about earlier, most of those algorithms have been built using retrospective, highly curated administrative data sets. So the reality is if we want to act and intervene, for example, deliver decision support in the clinical environment that's driven by AI, and we want to do that in a way that actually impacts patient outcomes, we actually have to deal with the data that we have in hand during that clinical encounter, which is not that retrospective administrative and claims data. So this was a study that actually demonstrated that if you took the top and most frequent mortality risk prediction tools that have been developed over a period of several decades and applied them to the raw data that was available in electronic health record, in this case across multiple academic health center settings, most of them performed about as good or maybe a little worse than a flip of a coin. So just to play that out, these are algorithms that work very well in a research context, but do not work well in a clinical context because they're built using the wrong data. And this is a frequent theme in terms of AI research and development, where we use highly curated, very complete, well-cleaned data sets that simply do not exist in the clinical environment and therefore preclude translation. Now, I will share with you, while it's not included in these examples, we have subsequent papers where we've shown that you can actually build deep learning-based models that perform as well as many of these published mortality risk prediction models and can reason upon raw, incomplete, messy EHR data. So this is not an insurmountable problem, but it does speak to, are you using the right task and the right data if your goal is to translate that algorithm into clinical decision support? And if we go to the next slide. And then if you scale to a population health level, you start getting into some of these issues around integration into real world workflow again. So this is actually an example of sort of an incidental finding that came about because of a long running collaboration between our Institute for Informatics and then our Alzheimer's Disease Research Center memory care clinics. So in our system, where we have a very large footprint in terms of Alzheimer care, we have specialty clinics for individuals with Alzheimer's disease-related dementia or a predisposition therein. And then, of course, we also have general neurology clinics where individuals who may be experiencing the symptoms of neurodegeneration will be seen. And one of the questions that was raised in this study was, is there a difference in access to specialty memory care clinics versus standard neurology clinics based on a variety of social determinants as well as demographic factors? And did that in turn have a correlation with long-term clinical outcomes, in particular, the speed of disease progression? And the answer is unequivocally it does, something that we anecdotally understood but had never quantified, which is that some of our most at-risk and underserved populations in the St. Louis metropolitan area, for a variety of factors, were also the least likely to access our specialized memory care clinics, and in turn had worse clinical outcomes. Now, what's interesting about this study is this actually came about because of another study that was being conducted to understand sort of the geographic distribution of these patients and thinking about sort of clinical workflow in terms of increasing access. And when we overlaid sort of these social determinant and other public data sets with our EHR data, we arrived at this conclusion. But I would draw your attention to sort of the visualizations that are produced as a function of sort of this data mining and machine learning exercise, which actually provide a geospatial sort of visualization of, at a zip code or census tract level, where those patients are indicated, what the sort of area deprivation indices are that are a surrogate for social determinants of care outcomes and access, and how that correlated with long-term outcomes. And the actual takeaway from this is that there's a very simple intervention, which is to think about transportation, access, and scheduling for individuals in these underserved areas to bring them into specialty memory care clinics and ideally improve their outcomes. But this is a simple solution, right? This is the idea of how would we act upon this? How would we present this data coming out of these advanced analyses in a way that makes it actionable, in this case, for hospital administrators that need to make decisions about how do we offer care services to these most at-risk populations. So if we go to the next slide. And this is something that should be familiar to some of the folks on this call who were involved in this. If you scale this problem up even to the next level and you think about replication of research across multiple sites, this is an example of a paper looking at a fundamental problem that has been explored for years in the informatics community, which is sort of the reproducibility of analyses that are used for phenotyping of patients and prediction of outcome across multiple sites and settings. In this case, using surrogate measures of diagnoses like those that we would use for type 2 diabetes, looking at the intersectional space of labs, diagnoses, and medications. In this case, just comparing a small number of academic health centers. And ideally, if we all documented and used this data the same way, these Venn diagrams would look identical. But as you can clearly see, they do not. And that's because the way in which this data exists within the EHR varies based upon local workflow, best practices, culture, and documentation standards. Also, as a sidebar, rarely do we see for inpatients admitted to the hospital, if they have type 2 diabetes, that type 2 diabetes is even included in their problem list. That's because the problem list is largely used for billing purposes to justify orders that are entered in the hospital, not for the purposes of creating an exhaustive list of all the conditions a patient may have, which is why we have these phenotyping algorithms. So if we want to build an AI solution that predicts outcomes for patients with type 2 diabetes, the first question should be, who has type 2 diabetes? And if it varies this much from site to site, you can quickly ascertain why reproducibility across multiple institutions in multi-center research, not to mention clinical operations, becomes so hard. And this is at the core of why AI does not travel well from one institution to another. So if we go to the next slide. Just to kind of wrap up and get to the Q&A, I do want to quote this phrase, which is not mine. It's from my colleague, Karandeep Singh, who's now the Chief Health AI Officer at UC San Diego. And I think it sort of summarizes some of the challenges that we face as a community, which is that, and I am going to read this, research models are rarely implemented and implemented models are rarely researched. So just sort of take a moment for that to settle in, because I think this is at the core of what we are facing in terms of the translation of AI into learning health systems today. By and large, we have the most knowledge about the performance of models that are produced for research purposes. And we have the least knowledge about the models that are being deployed for operational purposes, largely because they're coming from vendors without that rigorous research and development process. And this is a pyramid that we need to invert, because this is precluding the effective use of AI in the clinical environment. So if we move to the next slide. This is an example of what I just tried to describe in a nutshell. I'm sure many of you have seen this. This is a study that actually showed that vendor-generated AI algorithms for, in this case, our favorite topic, sepsis, largely performed at a level that made them not useful for any clinical decision making and mostly perceived as unreliable. And that's because of all the difficulties that I described to you earlier. Was the sort of task well defined? Did we have the right data? Did we know the evidence standard for assessing the performance of these models? Could they travel across sites? Back to my Venn diagram example a few slides ago. And then was it integrated into sort of clinical operations in a meaningful way? And the answer is that for many of these vendor-provided solutions, that is simply not the case, which is why there is so much work to be done in this field in terms of going from AI research and innovation to practice. And if we go to the next slide, showing that I'm not just picking on the sort of vendors alone and I'm equal opportunity. This is a recent research letter from our own research group, as well as with collaborators at OHSU, where we demonstrated that we could not reproduce the performance of sepsis algorithms, even with standardization within our own health system. So we took 9 hospitals in the BJC system, tried to optimize vendor-provided solutions for sepsis risk prediction, and still could not get them to work. So even if we sort of get to a place where we feel like we have enough control over the environment to address some of the factors I introduced earlier, that does not necessarily mean that we can get reproducible and rigorous results with these types of algorithms. If we go next slide. And this is just sort of the cheat sheet. If we had sort of a best case scenario and we put all the pieces together that we've been talking about today, every time we had an AI-driven intervention in this learning health system, we would incorporate all of these areas of both rigorous design and validation. Everything from needs assessment from the people that we're targeting as stakeholders to the model development and validation locally. Ideally, national scale validation is so transferability, and that's where large data sets like those being produced by Bridge2AI become so important. Making sure that we implement in a sort of tractable and performant way in the EHR. And then importantly, making sure that we tackle that last mile problem around workflow and socio-technical considerations. This is not a set of turnkey solutions. This is a place where every rigorous deployment of AI that goes from the lab into clinical practice in the learning health system requires a full spectrum of this type of scientific work and operational rigor to arrive at a positive outcome. So if we go to the next slide. And I will remind everyone, one of my favorite sort of sidebar comments, this is a whole other topic. There is sort of clear evidence that the healthcare environment in which we are trying to create these learning health systems, where we're trying to deploy AI, are examples of what are known in the software engineering and systems engineering literature as ultra large scale systems. And other examples of ultra large scale systems include things like power infrastructure or aerospace control systems. And there are well understood phenomena that require special design considerations in these ultra large scale systems, because we know that there's going to be diverse stakeholders, that you're going to have heterogeneous sort of components working together from a data, information, and knowledge standpoint, that the systems are constantly going to evolve and be dynamic, and that hardware and human failure alike will be the norm, and we have to design for and adapt to that. And I will say unequivocally that we basically ignore every single lesson learned in these other domains when we build these systems in healthcare. So one of the questions is, how do we get out of our own swim lanes and also understand sort of these lessons learned from these other domains to make sure that we can improve the translation of innovative AI solutions into the learning health system? Next slide. Yeah. And then just lastly, this is like my homework assignment for everybody. If you've not read Donald Stokes' book, Pasteur's Quadrant, I highly recommend you do. Remember, I said at the beginning of the talk that one of the challenges that we face is that we often perceive sort of this evidence to practice continuum as being unidirectional. And that's really predicated on sort of this long-standing separation of basic and applied research, right? However, I think the types of projects that we've been talking about today and sort of the change in the environment necessary to achieve this goal of an AI-enabled learning health system requires us to consider a third path, which is what Louis Pasteur described as use-inspired basic research, in which basic researchers immediately apply their knowledge in an applied context, evaluate, and then refine their theories and methods and repeat. And that there's not a unidirectional flow, but this is one and the same. I would argue that the separation of basic and applied research is a function of sort of longstanding historical constraint conditions imposed by human cognitive capacity that really no longer exist because of the computational tools we have today. So the question is, why do we continue to differentiate basic and applied research, whether that be in a biomedical context or in a computational context or both? Because if we're going to achieve this goal, again, of an AI-enabled learning health system, I think the only path forward is this idea of use-inspired basic research, which projects like this one are primary examples of sort of building the platforms and capabilities to make that possible. So I think that's the last slide. So I think at this point, it's perfect. We have like 10 minutes left. We can take some questions, and I think Andrea is going to work with Bill and sort of manage that process.
Yeah, thank you. Thank you, Philip and Andrea. Great presentation. Are there any questions? Okay, well, I have one. I enjoyed, the kind of showing the points where the model development fails. I'm also interested in the situation when the model succeeds, sometimes succeeds wildly, but it still doesn't necessarily provide any benefit. What sorts of research methods, and granted that AI is a lot harder to research than giving someone a placebo pill or a real pill. But what kind of methods will convince those that need to be convinced that these models that work well actually lead to better care and better patient outcomes?
Yeah, I'll give you like a high level view, and I'd be curious too, because Andrea has been digging deep into this issue of sort of how we sort of contextualize the evaluation of AI as well. But I'll start out by saying I actually think if you are trying to evaluate an AI intervention, and your goal is to sort of achieve adoption in sort of clinical operations, you actually have three primary audiences. And there's probably more than that, but I'll start with the three primary audiences. And each one of these audiences needs different data and information to justify the decision to move forward. So the first is the clinical audience, right? The sort of solution has to be in what I would describe as not explainable, but plausible. And I actually kind of dislike the use of the phrase AI explainability, because that often relates to sort of being able to tell people these were the features that inform the performance of the model. That doesn't necessarily tell you if the model performance is plausible given the sort of state of canonical clinical knowledge, and sort of builds upon sort of what we know from longstanding clinical practice or sort of the basic science that underpins that. So there's one sort of set of analyses which is really anchored around the plausibility of the model and its therefore acceptability to clinical decision makers. The second group are the technologists, right? These models are non-trivial to deploy in the operational environment, and I will spare you the excruciating details. But today, despite what you may hear, there is no quick and easy way to take an advanced AI-driven clinical decision support system and integrate it into clinical workflow at scale. The solutions, by and large, from the vendors are not computationally performant. They're difficult to engineer around, and therefore they require a lot of work to get from I have a working model to I could use this in my clinics and hospitals. So you need to be able to show that the architecture and performance of the model is something that works well. And actually, we often make trade-offs. I cannot emphasize this enough. I might be able to build a model that has phenomenal performance, but I might have a model that has slightly less phenomenal performance, but is also half or a quarter as costly computationally. I may choose to use the good enough model because it's computationally tractable as opposed to the highest performing model. And that has to be a factor when selling that computational performance. And then I think the third bucket, quite honestly, is the finance people. Because a lot of these models are expensive to implement, especially along with the workflow and other sort of real world changes that are required to sort of affect impact on patients. And so therefore, you have to have an argument that's either cost reduction or avoidance, or ideally revenue optimization. And I know that sounds very crass, but those are the two things that are understood. And frankly, cost avoidance is a much harder sales pitch to make because despite what we always say, we rarely reduce headcount and we rarely make changes in our operating models, even with improved efficiency. So in fact, to answer your question, Bill, I think you have to be able to design your project from start to finish to be able to, sort of answer questions for all three of those stakeholder groups if you're going to have even a shot of going into the real world. But I know, Andrew, you've also dug into this in great detail.
Yeah, I look at it, I come at it from, so I'm doing AI evaluation in the context of medical education. So measuring whether or not certain models can actually improve clinical reasoning for students. And so, basically it's assigning projects and having them use generative AI versus not, and then seeing, kind of differentiating between the two. But in terms of how you would communicate the message, we talk about and I selfishly like to talk about this because I teach it, but how do we present these stories in a way that draw in audiences? And as we mentioned, that AI is a piece of digital transformation, and digital transformation is an exercise in change management. And so it's getting a lot of stakeholders to really buy into it. And so coming up with ways to share those stories in a meaningful way that connects to each one of those groups is another value add.
Great. Other questions? Either unmute yourself or type into the chat. There we go. Steve Bedrick, I assume you guys can read that.
Yeah, so Steve is bringing up a really critical issue, right, which is sort of where fundamental trade-offs have to be made, I think, in an intentional way around bias, right? So you could have a model that has really great performance, but is sort of constructed in a way that performance is differentiated based upon subgroups of patients. And then you may have a model that performs better, but doesn't have sort of that potential source of biases in terms of stratification. And I think Stephen's 100% right. I would extend that argument even further and say, a lot of the conversation around bias today is around bias elimination. And that is certainly a laudable goal. But I don't believe that we can eliminate, let alone understand the impact of biases in our data sets if we don't measure it first. So I would argue that, like all scientific endeavors, the first question is, do we have sufficiently robust measures to understand the biases that exist in the data sets that we use to build these models? And then do we have a way to measure the impact of those biases on model performance? And then number three, how do we then arrive at sort of the trade-off that Stephen is alluding to? And I think if you start at the top of that sort of hierarchy of needs and you say, like, I want to make that trade-off, and you haven't sort of arrived at a shared understanding of sort of how we measure and understand bias and its impact on model performance, we won't get to a point where we can manage this. And I think it's like risk management. Like, people talk about risk management all the time. You cannot eliminate risk in computational systems. That there's the only not zero risk computational system is one that nobody uses, right? So beyond that, as soon as humans and computers start interacting with each other, there is risk. By extension, every time humans and computers are interacting around the development of models, starting with the collection of data, we will introduce biases. And so there is no bias-free system in my estimation. There are simply systems where we understand and do our very best to mitigate biases. And I think that requires new methods that we don't even have right now. I will go back, like, while just in the 2 minutes we had, there's a comment from early in the talk from Heidi about sort of whether or not human exceptionalism and intelligence is going to hold. I think it's a very fair question. I think today we could argue that we are dealing with AI systems, as I tried to make the case earlier, as did Andrea, are really sort of achieving impact as a function of speed and the ability to reason on volumes of data, information, and knowledge that humans cannot. That's today. I think given the rapid advancement, especially in generative AI tools and the aspirational goals to arrive at sort of these general purpose AI platforms, that may change over time. And I think the real question for us is, how are we building systems and the metrics today that allow us to sort of assess for that change over time? Because again, if we don't measure and try to understand that, it's going to be hard to know where the opportunities exist to use these increasingly advanced systems to improve upon human performance. And then there's the cultural dynamics as well as the social and ethical and legal implications that I think are poorly served right now. And that's another big part of Bridge2AI, right, is doing the fundamental work to sort of build those ethical, legal, and social frameworks to better understand exactly that type of question.
Okay, well, since we are at the hour and no other questions have emerged, I want to thank Philip and Andrea for providing this interesting talk. And we hope people will attend further webinars as part of this series. Thank you.
Thank you.